The Upper East Regional Hospital is appealing for equipment to help with diagnosis of childhood cancer treatment. Now, childhood cancer. Now, I think it's such an important area,
yes,
because for years, even up to now, there's been a lot of cry about our healthcare system. If you look at the issue of NHIS, childhood cancer, only recently, I think it was just
last week or so.
Last week or so, that parts of childhood cancer treatment got recognized by the NHIS, and then therefore there'll be some inputs from there. But I think it's such an important area, because what I'm not sure about is why all this while childhood cancer hasn't been, taken as a serious, area for our healthcare system to actually jump on and deal with. Because leukemia, all kinds of cancers affect children.
yes,
And so on and so forth. And I mean, you have private advocacies and people trying to raise funds on individual levels and so on. But I think that as a system, as a country, we need to do better. And look, right now, Upper East Regional Hospital is crying out. They need help. They need a lot of help.
yes.
You may look at it and say, well, I mean, there are other pressing needs, but which one takes priority over any?
That's the thing.
Everything is important.
That's the thing. Everything is important.
Yeah.
And like you said, this is equally important. So yeah, let's take a look at what they're looking for.
Yeah.
As you said, the Upper East Regional Hospital, they're asking for help with childhood cancer equipment to aid diagnosis.
Childhood cancer is a leading cause of deaths among children and adolescents. According to the World Health Organization, 400,000 children between 0 and 19 years are diagnosed of cancer every year. Data from the Ghana Health Service shows that cancer of the brain, kidney, eyes, liver, and tumors are the leading causes of death among children. As part of the National Health Insurance Authority's week celebration in the Upper East region on the theme, using the Ghana card for expanded health services, the authority announced a relief for children with cancers. Acting Upper East Regional Director of the NHIA, Kasimu Abdullahi, said the intervention by the authority to cater for some childhood cancers under the scheme is aimed at reducing mortalities.
Now we have roughly about 6 cancers covered, because originally we had breast and cervical cancer covered. Then now we are adding 4 childhood cancers. All other cancers for now are not included. So this is the first important highlight for this year. The second one is the inclusion of family planning benefits into the system. We piloted family planning in this region for 2 years, and research has shown that it is beneficial to put it in the benefits package.
Even though the childhood cancer intervention will save lives, the Upper East Regional Hospital, unfortunately, do not have the requisite equipment and specialists to take care of such patients. Pediatric ward doctor at the hospital, Dr. Gloria Abarike, says the government must resource the hospital with the needed equipment and personnel if the initiative is to succeed in the region.
This hospital, with regards to leukemia, we don't run blood from peripheral blood from common. Even if we are going to run it, it's expensive. Patients have to run it from outside labs, and some of them cannot afford it. Apart from that, the solid tumors like kidney tumors, nephroblastomas, and all that, patients come all right. You can make a diagnosis with an ultrasound. It will give you an idea of what is going on, but you need a CT scan and probably a biopsy further to confirm this diagnosis. We don't have a CT scan in this hospital. So if it's added to health, it will help us all right, but we need the capacity also to be able to make the diagnosis. Aside that, we need an oncologist who will be able to carry out with this, make these diagnoses correctly and treat them correctly and follow up to make sure that these cancers are cured.
Touching on the NHIA indebtedness to service providers, Mr. Abdullahi assured that healthcare providers under the NHIS should exercise patience as efforts are underway to clear all arrears owed them.
Some years back, we owed providers about 14 months of claims. But as we talk, we've paid most of them to around March, April 2021. Given the cyclical adjudication process of 3 months, usually it takes not less than 3 months to process claims when submitted. It means that if we paid up to around March, April, we are now in November, we are left with just about 6 or 7 months. If you take away the 3 months of cyclical process, we are roughly left about 3 to 4 months of indebtedness. And that's a massive improvement from 14 months to 4 months. That's massive improvement. And all efforts are on course to clear these bills. Hopefully by next quarter of 2022, all the bills will come to zero so that we shall live hand on hand. You submit your claim, we vet you and pay you on time.
Mr. Abdullahi reiterated that the scheme has chalked successes in its enrollment of subscribers, but not without challenges. Thus, his appeal for support.
All right, so that's a report there from the Upper East Regional Hospital. Yeah, it's a myriad of issues, Kokri. They don't have doctors.
Yep.
They don't have, they have doctors, but I'm talking about a cancer doctors, oncologists.
Specialists.
They need an oncologist specialist. They don't have the equipment. So I think one of the issues there, which is probably maybe the primary issue, is if they had the equipment and the capacity to diagnose. That's a start.
Yes.
So even without an oncologist, that's a start. You can diagnose. Now, of course, we know what cancer is. If you diagnose early, usually you give yourself a lot more chance to survive, right? So I think that for me, that would probably be the primary thing, to look at building capacity, helping them to be able to diagnose and therefore treat.
Exactly.
And then, of course, the larger conversation will then end up in actually having an oncologist, at that facility or within the region who can be accessed by these facilities as well.
Because as the pediatrician was saying, yes, they appreciate the fact that the NHIS is going to cover treatment of some childhood cancers, but until they have the equipment, as you said, until they have the personnel, they can't even diagnose properly, then what's the point of having the facility to cover the treatment when you can't even discover whether or not the child has the cancer to be treated? So it's like, okay, on one hand, yes, good job NHIS. We're glad you want to treat some children who have cancer. But how do we identify those children for you to treat them if we don't have what we need resource-wise? It's one of those things. Hopefully the government is listening. We hope. Okay, and they'll make the necessary assignments. And you made a good point off camera that, look, we've got many well-trained doctors in this country and nurses as well, because we need nurses who are also specially trained in cancer care and all of that. But for people who are that specialized and who have those particular skills, how attractive is it to move to the Upper East to practice there? Because even the facilities they need to do their work properly, will they have it? So if you are to transfer an oncologist to the Upper East Regional Hospital, will they be able to work to the best of their ability?
I think that one of the things that we've not done very well is creating incentives for people who choose to live in places that are further away from the center as much as possible. I think that too many times we have this system, and it's a culture where it's like a transfer. If you're being transferred, the further away you're being transferred, it's almost like a punishment. Right? But that should not be the case. Because, for example, Kokwi, we all know that living in Ghana is expensive. But we also know that the further away you are from Accra, the cheaper the cost of living becomes. Food is a major issue. Fuel generally across the country is the same. So whether you buy in Accra or you buy in Tamale, fuel is pretty much the same, right? But food tends to be cheaper when you move further and further away, right? Which means that the cost of living generally should drop as you get further away. That in itself is an inbuilt incentive. But how do you create these incentives in the spaces where you want your doctors to move to, so that when they are going out, they know that there's a benefit to my move? Do you see? Because I may live there for 15 years, I may live there for 20 years. Maybe my hope is to eventually come back and settle, right? If that's the plan, what's the advantage in the period that I'm out there, to be able to save money, to be able to, put away some good pension and all of those things? What are these incentives? Okay. If none of these benefits exist and it's going to be like a punishment for me to move out here, I'm going out there, what are the facilities that I even have to work with?
Exactly.
Do you see? Then what's the point?
What's the point? Okay. Well, Dr. Ifwa Kome is the program manager for non-communicable disease with the Ghana Health Service. Maybe she can give us a bit more insight into this appeal from the Upper East Regional Hospital. Good morning, Doc.
Hi, good morning.
Hi. Thank you for joining us on Breakfast Daily.
You're welcome.
So we've been discussing this story where in the Upper East region, the hospital there is, on one hand, they are happy that the NHIS will be covering some childhood cancer treatment. On the other hand, they are asking whether or not they'll be able to get some more resources, particularly equipment and even personnel, specialized doctors, oncologists, who will be able to help diagnose some of these children. From where you sit as the program manager of non-communicable disease, could you give us any updates on how that will be rolled out?
Certainly. Thank you so much for the opportunity. So, childhood cancers have been on Ghana's priority list for quite a while. Indeed, Ghana is currently undertaking a global initiative for childhood cancers, which is a support from WHO. This support became necessary because of the maldistribution of staff that we are currently experiencing. So for specialists, like the ones you are talking about, specifically we call them pediatric oncologists. These are trained specialists who are trained to take care of children that have childhood cancers. Ghana has very limited numbers of pediatric oncologists. Beyond the pediatric oncologists, there are trained nurse oncologists that are also on the ground. And what the Global Initiative for Childhood Cancer seeks to do is what we call task shifting, task sharing. All that it means is that beyond the specialized cadre of staff who would ideally treat children with cancer, we train non-specialized staff. So if you are taking, let's say, your community officer or community health nurse, or a midwife, or somebody who is delivering a service within a community, you would agree with me that the lower cadre of staff are much more than the specialized experts. So these lower cadre of staff are being trained in early detection.
Okay.
And what that means is that once they are able to pick up warning signs, they are linked up to pediatric oncologists in our main treatment centers. Unfortunately, the main treatment centers are Kolebu, Konfanote, and Abudu. And I think currently Somali Teaching Hospital and Cape Coast Teaching Hospital. But then we are linking up with institutional care such that we do have something we call the network of practice. And all that means is that although the specialist might be just one, the specialist trains these lower cadre of staff in the districts and then within the community so that he is supervising them. And once they have any suspicious case, they quickly call him. He would either confirm or direct them as to what to do. That is an interim measure while we are going on to train more pediatric oncologists in the field.
Okay. What sort of, Dr. Kome, what sort of incentives is the Ghana Health Service working with in terms of trying to encourage more medical personnel to specialize in these areas? Are you doing any? Do you have any kind of a program that you're working on?
There are quite a number of incentives. The main thing is that you do know that currently Postgraduate medical training has been, the cost of post-medical training has been taken by the government.
Okay.
So previously, training a pediatric oncologist is so expensive that even the colleges of training within Ghana were previously not undertaking the course. So they have to either go to South Africa or to Europe to be trained. So the few that we currently have were not trained in Ghana. Currently, a lot of work has been done with the Ghana College of Physicians and Surgeons and the College of Nursing Training, and they have both started the courses in pediatric oncology. Now, introducing these they are specialist courses, so the introduction tends to take a bit of time. But I think work started somewhere in 2018, and I know the Ghana College has currently taken on residents who are doing pediatric oncology.
Okay, fantastic. I mean, I think it sounds like good news that, first of all, government is taking on postgraduate training costs. And then also the fact that you do have certain incentives in place to get more people to get into this oncology side of things, you know, so we can, build up the system in such a way that it becomes better than what, we came to meet. I mean, for you, in the next 5 years, what are some of your expectations as far as, the programs that you're working on are concerned? What do you want to see for Ghana, let's say, in 5 years?
So within the next 5 years, it is our hope that we'll extend the treatment centers beyond the teaching hospitals that I mentioned.
Okay.
So when we say treatment centers, we mean that they are actually going to treat the cancer.
Okay.
And that means they need chemotherapy services, radiotherapy.
Okay.
It's quite an expensive effort.
Yeah.
But then we are working with quite a number. And thankfully, a lot of private sector agencies have come on board. And that is what is actually making this hope reality. Now, beyond that, we are also looking at these shared care centers that I talked about. So we don't only have to focus on our teaching hospitals. But if you are talking even district hospitals or health centers, some might have some medical officers or nurses who are interested in childhood cancers. All it means is that they are coached by the teaching hospitals and mentored. So they give a bit more advanced care than routinely just referring people because there's no pediatric oncologist in their center.
Yeah.
And this is being done in various hotspots around the teaching hospital. So the teaching hospital is serving like a hub, and then the various folks around will have these shared care centers. And the beauty of it all is that once these shared care centers are available, they can also be targeted by industry, so private sector industry, various API amongst others. Some of them have promised to adopt these centers and help to resource them so that our children with cancer, their outcomes will be improved.
Okay.
Great.
Fantastic.
Thank you so much,
Doc. We
Welcome.
really appreciate your thoughts and sharing
you too for the
your plans.
opportunity.
All right. Thank you.
I like the last point she made about private sector involvement, because
Yeah.
you see it in other jurisdictions where certain maybe the pediatric cancer wing has been named after a certain philanthropist, things of that nature. So I think she's right that private sector could also step up a bit, like she said, adopt a center, make it their own, resource it or help to resource it to supplement government's efforts. I mean, it happens.
No, I mean, I think for me, I think it has to be done in a cohesive, progressive manner. So they need to tell private sector, these are the areas that we need help in, and then private sector says, okay, fair enough. Somebody says, I want to take this. Somebody says, I want to take this, and so on. I don't think that when people are trying to make their own private money, it's the easiest thing to say, okay, let's go looking for hospitals that we can care of. But if you come
because it's not culturally, we're not like that.
No.
Other places they are. They actually people actually look for causes to support. But you're right. Here it's not so. You have to go and plead and cajole and coerce and convince, and unfortunately, but maybe we'll get there. Maybe we'll get there one day.